listened to Doug Van Nostrand speak and forcefully advocate his point of view, and I agree with a lot of it. But on this talk, I want to talk about PET and thyroid cancer of 2022. We have a great opportunity because of the advancement in technology, both in instrumentation and radiopharmaceuticals. I'm going to talk about FDG and I-124 today, and I'm going to talk about PET. Now, when we talk about PET in nuclear medicine, we're really talking about fusion imaging, a combination of high-resolution CT and FDG-PET. So common tumors are studied extensively. This is just a short list, and thyroid cancer is certainly on that list with FDG-PET. It's a tremendous addition to the diagnostic armamentarium. I think anyone in a cancer hospital certainly has to say that. Now, the main isotope that we use in isotope formulation is FDG, and that is a form of glucose which is taken up by cancer cells by the Warburg effect, which is an interesting property of cancer whereby they utilize the glycolysis as a way to not only energy, in fact, energy is only a part of it. They probably also need carbon backbones to build their DNA, and also they need the glycolysis to help control redox. When I was at the National Institutes of Health, as has been mentioned, I was fortunate to work with two real giants who made a huge impact on clinical tumor imaging. The first was Zelkaloff, who validated the concept of metabolic trapping of 2-deoxyglucose and laid the groundwork for FDG application, studying mostly normal brain. And then Giovanni Di Chiro, who conceptualized the application of FDG-PET in tumors. He's not talked about very much. He was a neuroradiologist. I worked with him closely. He recognized the value of Warburg effect for imaging and performed the first studies in humans. This is Lou Zelkaloff, who lived into his 90s, died at the University of Pennsylvania, as I understand it, still on the faculty. He developed this pioneering approach to deoxyglucose methods. And this is Giovanni Di Chiro. He's in a wheelchair, as he had been for nearly 40 years. An amazing guy. Read the literature in 5 different languages. And one of the papers he picked up was a little paper that we had published in the late 80s, suggesting that perhaps deoxyglucose might be interesting for imaging cancers. This was in an animal study. At least he told me that that had an influence in his decision to go forward. This is what he did mostly. Brain tumor, this is a glioblastoma. And there's also a grade 2 glioblastoma, and basically, as I said, widely applied. Now, I show these quick pictures of breast cancer as another endocrine tumor, and we took these tumors and we explored, for example, this is from our series, we explored what might be the mechanism whereby FDG uptake has occurred. And we were able, working with Ingo Milanoff and Alex Miller, a fellow, we were able to control both FDG uptake and correlate the SUV of uptake in individual lesions with this approach of looking at high uptake and low uptake using a gene set enrichment analysis. We look for an FDG signature, and what we found was that out of 103 canonical pathways, that the most highly enriched in the high expressors was this one, which is glycolysis. So no doubt that it is glycolysis. And the other interesting feature that goes across many tumors, including thyroid, is that the higher the FDG uptake in a tumor, the worse the tumor biology and the worse the prognosis. Now that brings us to thyroid cancer. And here's a patient of ours that we studied about 10 years ago who had papillary thyroid cancer with a terrible outcome. Ultimately, this patient died. This is an FDG-PET scan, and you see the tremendous localization in multiple tumors. We're looking at a MIP image. We published a number of papers in collaboration with my colleagues in endocrinology, and tremendous amount of credit obviously goes to the endocrinology group. But it's more than that. It's a collaboration, which I think is going to be essential for working out our problems as we go through development of dosimetry methodology. I'm going to talk about a couple of these papers related to prognosis, related to the relationship of FDG and uptake of iodine, and then talk about a couple of other papers, one on Hürthle cell cancer, the role of FDG, and then also a paper from Jim Fagan's group on BRAF. First of all, FDG localization in cancers is a bad sign. And here you see that in the positive FDG tumors, for example, we see much worse survival than in those that are FDG negative. And there are other features that you could correlate. They're also bad. For example, the volume of FDG functioning tissue. That's terrible. If it has really high volume, the patient doesn't have long to live. There is a relationship between the FDG uptake and the radioiodine uptake, and it's inverse. So this comes from a paper that was done by Robbins, Tuttle et al. While we were there, and basically what we see is the relationship of iodine uptake and FDG uptake in a group of lesions. We see that the more FDG uptake there is, the more poorly does the patient concentrate radioactivity. So in summary, as far as the DTC goes and FDG, the uptake correlates with a poor prognosis. In regard to FDG, if the thyroid globulin is greater than 10, or it means that it's significantly elevated without stimulation, we know that that's a bad sign, and the FDG-avid disease is more likely to be RAI refractory. Now, advanced Duracell cell cancer is interesting. It's only 5% of DTC, but FDG-PET turns out to be a tremendously useful initial staging and in monitoring progress and or response. I also want to mention that in RAI refractory disease, most of the PET positive Mets are enriched for BRAF mutations. So first, talking about Hürthle cell, 5% of DTC. This is the study from Dan Prima, who's now chief of nuclear medicine at Penn. He looked at 44 patients. This was when he was a fellow of ours, 24 positive, 20 negative. He found the specificity was 99% and the sensitivity 95%, the specificity 95%. Can't do much better than that. Also, I want to mention the role of a genetic profile. This is a mutational profile, and in patients with positive FDG metastatic disease, virtually all of them, 9 out of 10, I think it was, had BRAF expression. We're fortunate with thyroid cancer that we have so many great isotopes of iodine, obviously for therapy, I-131, but also I want to talk about I-124, which I think is the future for diagnostic imaging of differentiated thyroid cancer and lesional dosimetry, as you'll see. Here's a patient of mine who had metastatic disease throughout her bones, ultimately died, just tragic. Very good localization, as you could see, but she just progressed. There wasn't anything we can do. We tried more than 1,000 millicuries of I-131. And what we needed, though, was better dosimetry. We actually, although there's bright uptake, we really don't know how many rads we're delivering to those tumors. Now, one of the things that stimulated our interest in looking at lesional dosimetry tremendously was the work of F.A.C.N.P, Ho, Tuttle, and the team about the problem of RAI refractory thyroid cancer. I think that's why it's so relevant in the discussion that Dr. Van Nostrand opened up that about RAI refractory thyroid cancer. We know that RAI is very important because patients die of their metastatic disease, and decreased uptake is a cause of higher mortality. And we need new therapies for these RAI refractory thyroid cancers. We see there's early promise of MEK and BRAF, and I'll show you that a little bit about that. Let's talk a little bit about this differentiation therapy. This is a cartoon to make it easy. This is the MAP kinase pathway, and these are the main players in transporting the signal down to ERK, which again is the sort of guardian of proliferation, if you will. And we know that many of the mutations come from this pathway, as we've heard. Now, we did a study with MEK that was published in the New England Journal. Alan Hogue, outstanding medical oncologist, was the first author, looking at selumetinib enhanced radioiodine uptake in advanced thyroid cancer. The objective was to assess whether by blocking this MEK, which is just downstream of BRAF, the most frequently mutated. Maybe say Jim. I don't know if Jim hears me, but he needs to mute.
Yeah, I'm here.
Is that you? Oh, it's not you, Jim. I thought it was you, but it's not. I don't think we're, somebody needs to put on the mute. There we go. Anyway, so this is what was done, and this is the baseline study with IL-24 looked like this in that patient. Actually, you've already seen this study, but here's what was done. This is the protocol. So we did thyrotropin injections. We always use recombinant TSH in our studies, both for therapy and also to stimulate uptake. It's very convenient for this. So the patient had a baseline, then the patient had a 4-week course of selumetinib, then we had a repeat study, and if the patient was positive in response with uptake, the selumetinib was continued, and we went ahead with radioiodine therapy if it was above threshold, and if not, we discontinued. Now, there's so much talk, been so much good information about the genes. I'm not going to talk too much about the genes, but those of you in nuclear medicine will appreciate. This goes over the course of a month, from no uptake to very bright uptake in the lung. To me, that's amazing. And here's also in the right supraclavicular fossa. You can see we plotted it as an after and before. So I want to point out that not all of the lesions actually responded completely, but you see there was a tremendous range of uptake. This shows the after treatment effects ranging from up to 200 SUV. Anything above 20 is above our threshold. As you can see, there was a little bit of uptake at baseline, which is interesting and what we often see. But what the selumetinib did in this patient was made it much more homogeneous with very good uptake and localization. Another example of another patient. This is a patient showing again bone disease. So that you can reinduce the iodine uptake in bone disease. This is the baseline. This is the post-treatment in this PET CT fusion image, showing tremendous localization in a lytic and very active tumor. Here again in the skull, you see very good uptake. The point I want to make here is that there were 8 patients here who were treated, and all of them had a response. In fact, they all showed a significant thyroglobulin drop. 2 of them did not quite make the criterion for RECIST. This was done at 6 months. So these are persistent responses. So my interpretation is this is proof of concept that yes, you can induce clinically significant changes in tumors. But what we have not done yet, and what we must do now, is begin to implement this actually into clinical paradigms and to test it carefully for patients such as this. And that is the work that Alan Ho is doing, and he has extended this to multiple other tumors. So this approach, enhanced iodine incorporation, it was dependent on tumor genotype, as we've heard. All 8 patients benefited from this with the induction of RAI, and also 6 of 8 had a PR, and 8 of 8 had a TG drop. Just to show you, we chose to do the dosimetry. We chose a very simple model. We took a single time point, 48 hours, and we guessed that the clearance was 48 hours. Turns out that as I'll show in my next talk, 48 hours was a very good guess, but the half-life was too long. Actually, most of the lesions do not change very much if they get to that point where they're really, really responding. This is a simple dose. A simple way to do it, you simply multiply the effective half-life times the amount of radioactivity times 1.4 to get a area under the curve. Those of you in nuclear medicine will appreciate that. And then you simply multiply that area under the curve times this delta here, which is the dose constant for iron-31, which is 0.405 gram radians per millicurie. I mean, for gram radians per gram times the microcurie hours under the curve, and you get the dose in centigrade. Another example of the brightness. This was the whole series. Alan Ho has been doing studies with other inhibitors, some even more potent, such as trametinib. He's gotten very good response. Just for the nuclear medicine guys to see some of the images. I mean, these are unequivocal changes with very short, few-week intervals. Treatment, demurafenib, you see the uptake here. In these MIP images. Once again, very good localization in these patients. So PET-CT is a tremendous tool for clinical practice in thyroid cancer. PET-CT FDG is a marker of dedifferentiation and poor prognosis, but it's very useful for staging advanced disease, especially when iron-31 or iodine radioactivity is not taken up, and also in peripheral cell, particularly monitoring treatment response. And iron-24 is a very promising theranostic in advanced disease, and as we'll talk about in the next talk, we're trying to use that to build a new way to look at dosimetry. We did find that 48 hours as a single time point did provide us a threshold that was useful for predicting and selecting patients that were likely to have a real structural change in size of tumors with iron-31 therapy. So thanks very much for your attention.